My name is Max. I'm a nationally registered EMT and a licensed EMT in the state of Florida. Today I'm going to walk you through how an EMT is trained to respond to an emergency step by step.
You gotta help me.
Chat, check this out. Oh my god, look, this guy literally just got shot. Oh my god. GTA 6 in real life? Oh my, look at this guy. Chat, can we get a hype train going for the guy that just died here? Yo, come on. Bro. Mogging this guy right now, look at him. Don't be this guy. Let me tell you how. Before we begin, I'd like to clear up a few things. I'm an EMT, not a physician. In no way do I want you to think I'm a physician during this video. This following information is not medical advice. This video is for educational purposes only. If you're in a real emergency, call 911. So let's dive right in. The very first thing an EMT is told to worry about is themselves. If you do this job for a while, you're gonna have patients with infectious diseases that you don't want. To help prevent that, the first thing we're worried about is personal protective equipment, or PPE. This is typically just gloves, but it's sometimes a mask, eye goggles, or a gown. The main goal of PPE is to follow a protocol known as BSI, Body Substance Isolation. If you only interact with patients through a disposable barrier such as gloves or a gown, you reduce the risk of those infectious diseases actually having any way to contact you specifically. If you're witnessing a medical emergency and you're not a medical professional, chances are you know the person or the person's family or friends. While you should definitely wear PPE, for an immediate family member, I'm not too worried about grabbing gloves. The next thing an EMT is told to worry about is the safety of the scene. The easiest way to make a medical emergency worse is by making yourself a patient. Not only are you going to give the EMS crews that show up more work to do, but you're delaying actually giving help to the person who needs it. Regardless of everything else, if the scene is not safe, EMS cannot do anything. There has been a progression towards a more dynamic model for active shooting incidents using law enforcement that also have EMS credentials such as SWAT paramedic. But for most situations, EMS is staying entirely off scene until it's 100% secured and safe. As a witness to a medical emergency, that's the ultimate thing you should be worried about. Why did that patient become a patient? Are you going to be next? If not, are there any scene hazards you need to consider, like a car on side, a knocked over utility pole, maybe a gas leak? Also, this can be tricky because at what point is a scene no longer safe? I've had a call where I was a student in an ambulance with an EMT and a paramedic. We get on scene to a house and they have a massive dog who appears to only be aggressive towards me and me only. Not the EMT, not the paramedic, just me, the student. So at what point do I say the scene is no longer safe? Because the dog is just sitting there staring at me, barking at me. Is the scene safe? How aggressive does this dog have to be before I finally consider this scene no longer safe? It's crossed that line. It's a very gray area. After scene safety, we're told to think of mechanism of injury, or MOI, or the nature of illness, NOI. A patient has a mechanism of injury when they're victim to a traumatic injury. A traumatic injury is usually something resulting from extreme force to the body. There's blunt force damage just from the force transferring through the tissue, or maybe force from a sharp object that creates something like a laceration. The specific MOI is exactly what happened to them. A car accident, a fall from a ladder. A nature of illness, or NOI, is a term for medical patients who are suffering some sort of medical emergency. This can include a myocardial infarction, typically known as a heart attack, or an exacerbation of a more chronic illness like asthma. This is commonly confused with something called a chief complaint. A chief complaint is what the patient complains about in their own words. A chief complaint is typically what's described on the radio when a call goes out. This is so dispatchers aren't actually assuming anything and are just stating what the patient says to the responder. For example, an NOI, or nature of illness, might be a myocardial infarction or heart attack, but the chief complaint will be crushing chest pain. Determining this early is important because high energy trauma dictates how you physically touch the patient. For instance, immediately stabilizing somebody's head if they've suffered head or neck trauma to prevent spinal cord damage. The next thing we're worried about is determining number of patients. This is very self-explanatory, but it can be confusing if you're in a medical emergency yourself. Imagine you're in a car crash and the other vehicle has 2 passengers. You're fine, but one of the passengers in the other vehicle complains of wrist pain, while the driver of the vehicle is completely unconscious. So in that case, do you have 2 patients or do you have 1 patient? Pretty hard to determine on the spot, especially when their conditions are so different. Typically, if you have more than 1 patient, EMS will start using something called triage tactics. There's multiple different types of triage tactics. I think the one that the NREMT really prefers right now is the START triage method. Basically, the whole goal of triage is to get the limited resources that EMS has to the patients who need it most first, and then the people who don't need it as much get it second, and the people who need it the least get it last. They do this through various assessments and stuff that I can't really teach you in this short of a video. So if you call 911 and you're confused as to how many patients there might be, just better safe than sorry. In that example with somebody with a wrist pain and somebody completely unconscious, say there's 2 different patients. So now that we know you don't need to run away, what happened, and how many people it happened to, you need to start thinking about how many resources you need. For an EMT, that might mean calling something called ALS backup, which stands for Advanced Life Support. Ambulances are classified into 2 different groups: Advanced Life Support, Basic Life Support.
ALS and BLS. From the outside, these ambulances look basically the same, but on the inside, there are a few key differences that let ALS ambulances carry a lot more serious calls. ALS ambulances have a paramedic on board, along with medications and advanced airway devices. An EMT and a paramedic are not the same thing. Becoming an EMT takes about 6 months of full-time schooling, while becoming a paramedic takes about 2 years of full-time schooling if you include EMT school. So having one on the truck that can do more advanced things with more advanced items might be important for certain calls where somebody's airway might be compromised. This could also mean calling in a helicopter for a medevac, but that's obviously something you wouldn't be requesting over 911. I do think Joe Exotic did that in a documentary though. If you're a bystander, this step just means calling 911 when you confirm it's safe to do so. Don't spend 5 minutes trying to figure out what's wrong before you make the call. When you call, watch out for the bystander effect. Make sure that you're actually calling 911, or if you're helping the medical emergency, that you are immediately pointing at one person and directing them, hey, you, call 911 now. I will say, however, this isn't as common as people say it is. I've been to a lot of medical emergencies where I'm a complete bystander, and I'll see people calling 911 so much that the phone lines are hanging up. A good rule of thumb is it's generally better to just call them. Doesn't take up any resources. I've done that before. I saw an unresponsive homeless man laying out in the middle of the sun in like a 100-degree day after a football game. So I called 911. I was like, hey, this guy's completely unresponsive, laying on the side of the road in the middle of the sun, possible heat stroke. And they just said, hey, is this a man with, green shirt, black shorts? There's somebody already en route. That's it. You're not going to get punished. You're not going to get penalized. Might as well just call. The next thing we're worried about is C-spine immobilization. C-spine means cervical spine, which is the part of your spinal cord relating to the bones at the top of your neck. This is very important since people who have possible head or neck trauma could have it made worse if you don't immobilize the C-spine. So if you ever seen somebody with a cervical collar on, the thing that goes around to the chin and keeps their head straight like this, that is in order to immobilize their neck to make sure it doesn't get injured more by moving it around while they're unconscious or something. So if somebody has suspected head or neck trauma, a great thing you can do as a bystander who's there on scene before EMS is to just hold C-spine. Hold their head and neck straight and just make sure it's not moving. Because people who go unconscious typically don't stay that way. So they might come to and start trying to move their neck and do all this. What you could do for them is just hold their head straight and say, help is coming. Please keep your head straight. This is very important for car crash victims who might slump their neck over like this, or might start moving it around as they start to wake up. You can just get in the back seat behind them, hold their head straight. So all of that was just completed is called your scene size up, right? Your scene safety, chief complaint, MOI, NOI, all of that is completed before you even assess the patient in any type of way. The next category of steps is called the primary assessment. As a bystander, this is the number one place where you can make a difference, because the goal here is to find and fix immediate life threats. As EMS, this is the step we do before we get vitals, before we do a head-to-toe assessment, before we even put them in a stretcher. This starts with a general impression, a quick little 3-second glance up and down at the patient as you approach them. Are they sitting upright and looking immediately at you? Are they slumped over and pale and clutching their chest? An example of this would be, I see a 20-year-old female laying supine. It's usually age, gender, posture. Next, we evaluate their level of consciousness using something called the AVPU scale. AVPU stands for alert, verbal, painful, unresponsive. If somebody is alert on the AVPU scale, it means when you walk up to them without speaking, they immediately look at you and notice that you're in the room. When somebody is verbal, it means that when you walk into the room, they don't notice you immediately. But then when you go, hey, my name's blah, 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 they immediately notice you and look at you. If somebody's alert to painful stimuli, it means that they're able to respond not to your voice, not to your presence, but if you do something painful to them, like a sternal rub or a trap squeeze. And then the most critical of all is unresponsive. If you've walked up to somebody, introduced yourself, done a sternal rub, and there is no response at all, they are fully unresponsive. We check this early because brain tissue is sensitive to oxygen loss, making mental status a strong indicator of overall blood flow, or what we call perfusion, oxygen actually getting into your cells. Additionally, the less responsive somebody is, the more they lose something called muscle tone. The more muscle tone they lose, the less control they have over muscles like their tongue, which might cause their tongue to go back into their throat, obstruct their airway, interrupt oxygen flow. So once mental status is established, we start checking the body's primary systems, basically all focused on oxygen. Historically, we taught the ABCs: airway, breathing, circulation. Modern emergency medicine has updated this to XABC. The X at the beginning stands for exsanguination. Exsanguination is a medical term for bleeding out. The whole point of the system is to look as upstream as possible when we're trying to figure out how oxygen is not getting to tissues. So oxygen comes from the air, goes into the airway, and then from the airway into the lungs, from the lungs into the blood, from the blood into the tissues. We're trying to figure out what part of that process is getting disrupted so that we can try to do something to immediately fix it. The logic of that pathway is what originally made the ABCs. You need A for the airway, B for the breathing, and then C for the circulation, your last priority, right? So that pathway of air into the airway, into the lungs, into the circulatory system is the whole reason behind the A, B, C's, right? A good reason for XABC being a thing as well. If you completely starve somebody of oxygen coming into their airway, their brain will probably survive for about 4 to 6 minutes. Now, if you sever somebody's femoral artery, they will die in about 3 minutes. Therefore, that femoral artery is more of an immediate threat to their life than their airway. The way to stop bleeding is to use direct pressure or a tourniquet. In order to actually know what you're doing with those things, I recommend getting a certification from a Stop the Bleed course. But if you try to manage an airway on a patient who's actively bleeding out, you're essentially just pumping air into a system that can't accept the oxygen because it has no blood to carry it. So that being said, control bleeding, direct pressure, tourniquet, whatever. Once you're done with that, move on to the airway. You need to make sure that there's an open path for air to reach the lungs. If a patient is conscious and speaking normally, their airway is open. You might get that if they're alert. If they're unconscious, you have to visually open the mouth and inspect to make sure that there's nothing lodged in there, that their tongue isn't falling back onto it. But if their tongue is usually falling back onto it, you'll hear something like snoring. You might also visually check to see if there's blood pooling in there. Usually if there's blood pooling in there, you'll hear something like gurgling. I've often seen snoring and agonal respirations be mixed up. Snoring is an immediate airway issue. Agonal breathing is an immediate breathing issue. I've seen police body cam videos where they'll show a suspect who has quote unquote agonal breathing and the cops just stand around doing nothing. Meanwhile, it's not agonal breathing, it's snoring. Their tongue is depressed against the back of their throat, preventing air from getting into their body. The easiest way to fix that is doing something called a head tilt chin lift or a jaw thrust. We choose which one we do based on the suspicion of neck injury. If somebody was in a car crash, we'll do something called a jaw thrust because we're suspecting neck or spinal injury and we don't want to move the neck. If somebody has no possible neck or spine injury, we'll do something called a head tilt chin lift. So next up in this step of the primary assessment is breathing. We verified that air has a clear path to the lungs. Now we need to check if the lungs are actually moving air themselves effectively. We do this by checking the rate, depth, and ease of the breathing. This is where an EMT can apply oxygen or positive pressure ventilations of some sort. But as a bystander with no equipment, you're kind of out of luck. What I would do is I would just observe and report to a 911 dispatcher about what's going on. For example, right now I'm breathing at an adequate tidal volume at a normal rate with no accessory muscle use. Now, if you shot me in the chest, ouch, why would you do that? But I'd probably be breathing much more rapidly with inadequate or uneven depth, and I'd have very labored respirations. So now finally we evaluate circulation. We verified that air can and is moving from the air down the airway into the lungs. Now, is the blood in the body able to accept that air from the lungs? In order to do this, we check both pulse and skin signs. When there either isn't adequate blood or isn't enough oxygen for the blood, the body will shuttle that oxygenated blood to the main tissues and organs of the body in order to preserve them. What this results in is something called inadequate perfusion for your limbs and your skin. This will show on your skin as you being pale because there's less red blood in your skin. The skin being cold because again, there's less warm blood in your skin, and you being quote unquote clammy, which means your skin is a little bit sweaty and damp. This is because those limbs are being deprived of oxygen and it's having the same sweat response as you would normally have if you're being deprived of oxygen by going for a run or something. We check for a pulse at the wrist, but that's only for conscious patients. This is called the radial pulse. It's on the thumb side of the wrist, and it's about 2 inches back from the palm. You usually place these 2 fingers there because other fingers might have a pulse or shake that you might feel. And if you just place them there, you should feel a pulse. We check that for conscious patients, but we check a carotid pulse for unconscious patients, which I'm sure you've seen in TV shows and whatnot. This pulse is typically stronger. You can feel it in your neck right here. There's like a big neck muscle, and then there's your actual trachea and airway. If you go between the two, with 2 fingers, you should feel a pulse. And that happens on both sides. Make sure you're only checking the pulse on one side at a time though. If you check both sides, you're clamping down on the vessels that bring the oxygen to your brain, which is obviously a bad thing. And we check this on unconscious people. And I have a good story to say exactly why we do that. I was getting into an ambulance for my clinicals when I was doing my EMT school. This clinical was early in the morning. I think it started about 7 a.m. And normally this first 30 minutes of this 12-hour shift will be getting assigned to a post, maybe going to a gas station, grabbing some breakfast, then going to the post, and sitting around waiting for a call, and then usually after about 30 minutes, we'll get a call. This shift was different though. The second we get on, we are given a call code 3, which means lights and sirens, because a child had passed out at a church. And while we're en route to this call, this is a very normal call. It's called syncope, when somebody suddenly passes out for no known reason. We get told over the radio, try to step on it a little bit. Nurses on scene are saying that they can't find a pulse. From syncopal episode to cardiac arrest. just like that. And the reason for that is because the nurses on scene were not assessing the correct pulse. They were assessing a radial pulse. So I'm in the back of this ambulance and I don't get any of the call notes or extra information. I just hear whatever's on the radio. So as a student, it's my 3rd or 4th ever clinical. I just stepped foot on the ambulance. I woke up maybe an hour ago and I'm getting ready for my first cardiac arrest call ever. I'm throwing everything on the stretcher. I'm putting gloves on already, extra gloves in my pocket. I'm ready to go. And then we get on scene and she's standing up eating a granola bar, and she just steps into the ambulance by herself. So what really happened there? She had a syncopal episode, but she was an underweight adolescent female, which resulted in her having a very low blood pressure. So when she stood up, something called your orthostatic blood pressure, suddenly gravity is acting on the vessels in your body a lot more, trying to drag all your blood down. So your heart needs to pump harder in order to make sure that doesn't happen and drain all the blood from your brain and cause you to pass out for a second. That didn't work because her blood pressure was so low. So she had a syncopal episode from her low orthostatic blood pressure. The nurses on scene assessed a radial pulse instead of a carotid pulse. And the reason we don't assess a radial pulse for unconscious patients is because it disappears. And the reason it disappears is because the radial pulse itself disappears at a systolic blood pressure below 80 millimeters mercury. So now what does that mean? A typical blood pressure will be 120 over 80. And a systolic is the top number, 120. So when somebody's at 80, they have a very low blood pressure. But what does that have to do with somebody passing out? Well, typically the number one cause of a syncopal episode or somebody losing consciousness is because their blood pressure is so low that it's not pushing enough oxygen to their brain in order to cause them to stay conscious. So the cause of somebody passing out is typically the reason why their radial pulse will go away. So then you go to a carotid pulse. We do this because you don't lose the carotid until you're below about 60 millimeters of mercury. So if you're in that range of 60 to 80, you're gonna have no radial, but you will have a carotid pulse. Now, this could go even a step further in the emergency room. You might see doctors check a femoral artery because you lose that at about 40 millimeters of mercury. You don't typically see this in the field. Anyways, when we check this pulse, what we're looking for is rate, rhythm, and strength. Is the rate fast, slow, or normal? Right now, my heart rate is normal. My rhythm is normal. If you see an irregular rhythm, that's a really big red flag that something really bad has happened to either the brain or the chest. And the strength is kind of like a feeler for how high their blood pressure is. Going back to that story, when we got that patient into the ambulance, I could not find a radial pulse on her. I couldn't feel it even when she was conscious. I think her blood pressure was 94. So there's some people where it's just harder to feel a pulse, so it might feel weaker. There's some people who might have a really strong pulse, but that means that they have a really high blood pressure. Your blood pressure is the amount of force acting on the outside walls of your blood vessels, which is immediately felt by the pulse. I mean, this essentially tells us at a glance whether or not to perform CPR, right? Because if we see somebody who's unresponsive, they're not breathing, and now we touch their pulse and we feel nothing there, which is called asystole, we usually would begin CPR. We've gotten enough evidence already somebody's in cardiac arrest, and it's also kind of just a feeler on whether or not we need to start treating for shock. Regardless of somebody's ability to respond to you, regardless of their airway being clear and their ability to breathe, if they have pale, cool, and clammy skin, then that means perfusion is being interrupted somehow and we need to treat them for shock. Even if it's something that we can't do anything about, like septic shock. By we, I mean EMTs. We just need to bring them to the hospital immediately. In septic shock, blood flow is being interrupted, but we can't do anything about it in the field. What we can do is treat for shock. And basically the idea of that is push as much oxygen into them as possible. So we give them something called a non-rebreather mask with 100% oxygen. The atmosphere has only about like 21% oxygen that you're breathing in. So we're taking that oxygen, we're putting 5 times more oxygen into their system. We're trying to conserve heat because the body's going to waste energy trying to generate heat. So we put them in a blanket. We lay them supine so that they're more comfortable and so that the blood can pool easier to the important organs. And then we rapidly transport them to the hospital. And we can do all this without actually getting a heart rate, blood pressure, blood glucose, all these different vitals that we might do in a secondary assessment. So going back to what I was saying about the skin, we check the temperature, color, and moisture. So pale, cool, clammy, warm, pink, dry, etc. There's a famous quote about shock describing it as a momentary pause in the act of death. And that's exactly what it is. It's something that ancient humanity would just be part of the dying process, right? If you go into shock, you're dying and there's nothing you can really do about it. But now shock acts as this timer that's set as soon as it's on set, where it's like you have this certain amount of time to reverse whatever's causing this before the patient dies. Now it's a critical time for EMS to perform life-saving interventions rather than just accepting it as part of the dying process as ancient humans might have. So that's the scene size up and the primary assessment. You went through scene safety, C-spine immobilization, all of that, and then you went into XABC, and now for the EMT, you make a transport decision usually at this point before you go into your secondary assessment. As a bystander, your job is done. You've completed everything you can. There's no point in doing a head-to-toe assessment and trying to splint somebody's extremities or something, because that isn't immediately life-threatening. If it's immediately life-threatening, you have addressed it in the primary assessment. Your biggest job as a bystander, in my opinion, is honestly stop bleeding, do compressions for somebody with cardiac arrest. And more important than those two, call 911 immediately. The NREMT skill sheet is essentially designed to give actual EMS providers a true north when they arrive on a chaotic scene. It's very easy for your mind to go blank in a medical emergency, or even just when you have an unexpected challenge. I've heard stories from paramedics with years and years and years of experience tell me about times when they were on stressful calls, so stressful in fact that their mind just went blank and they just defaulted back to the NREMT skill sheet and went down it in their mind. For example, a 2-year-old cardiac arrest call. It might be easy to memorize this stuff and say, oh yeah, I'm just gonna figure that out on scene, but when you actually get there and a mother's screaming in your ears or something, that paramedic, even with years of experience, might freeze up a little bit. So being able to have a default that you've trained on that you can just do subconsciously is so important for EMS providers and might be important for bystanders as well. If you enjoyed this video, make sure to like and subscribe. If you didn't enjoy it, tell me why in the comments. I want to know why. I'm very interested in your feedback.